Hello, hi everyone. So this is another lecture for you. The lecture for today is sequelae of wearing complete dentures and how to manage them. Now, in the last appointment, we had covered the denture insertion, denture trying, and what happens after the patient wears the dentures or wears them for a long time. Specifically, what are the problems associated with wearing ill-fitting or poorly fitting dentures? So the learning outcomes expected are you should be able to discuss the sequelae caused by wearing complete dentures. You should be able to describe the etiology and the management of different sequelae caused by wearing complete dentures. You should be able to describe the interaction of the prosthetic material towards with the soft tissue, and you should be able to list the consequences of residual ridge resorption. So moving on, now some of the direct sequelae of wearing ill-fitting dentures are is denture stomatitis, that is inflammation of the denture bearing area, flabby ridges such as specifically what we see in the anterior maxilla or the anterior mandible, denture irritation hyperplasia usually occurring because of chronic irritation from wearing ill-fitting and unclean or unhygienic dentures, traumatic ulcers because of the poor fit and the settling of the denture causing pressure in the peripheries of the denture, especially labial and buccal flanges that may cause traumatic ulcers, chronic ulcers, and ultimately these ulcers become precancerous and cancerous lesions if not treated properly. Some patients may also encounter burning mouth syndrome, especially common in females with poor nutrition status and postmenopausal females. We should ascertain the cause. And also, sometimes patient may experience gagging because of overextended denture, post-dam areas, and of course, residual resorption, which is an ongoing and continuous process after the loss of the teeth. And in some cases, such as overdentures, or we may also see caries or secondary decay and periodontal disease of the abutment teeth. So, what are the indirect consequences of wearing complete denture? These are namely atrophy of the masticatory muscles to reduce vertical dimension or the poor facial support from the dentures, and indirect and nutrition deficiencies owing to lack due to wearing ill-fitting or poorly fitting dentures that are not suitable for mastication and may result in nutritional deficiencies because the patient is unable to chew the food properly. And first is direct sequelae is the denture stomatitis, which is one of the most common sequelae of wearing ill-fitting dentures or dentures with poor hygiene. So pathological reaction of the denture most commonly seen in the hard palate, and this is how you can see how denture stomatitis looks. And it is also called as denture induced stomatitis because it happens in complete denture wearers, is not seen in non-denture wearers, and also known as denture sore mouth because the mouth appears sore and tender and the mucosa is inflamed, edematous, and has a papillary appearance. And that's why it's also called as inflammatory papillary hyperplasia or the chronic atrophic candidiasis, because most of the time denture stomatitis, if left untreated, is accompanied by secondary candidal infections in the because of the denture stomatitis and because of the poor hygiene and the accumulation of food deposits in the denture bearing area or the denture fit area. So the classification of denture stomatitis was given by Newton. It is broadly classified into type 1 to 3. Type 1 is simple localized inflammation or the pinpoint erythema, hyperemia. And type 2 is erythematous and generalized denture stomatitis. And type 3 is a granular type of mucosal appearance in stomatitis, which is seen in chronic cases. So these are the pics that show, and this is a granular type of denture stomatitis, usually seen just posterior to the rugae or involving the rugae, and it has a mulberry or raspberry appearance, and they are granular and papillary in texture. And the etiology, as I mentioned, is because of patient wearing both either due to excessive wearing of the denture, trauma from an ill-fitting denture, and there are also certain systemic and local factors, such as more commonly seen in diabetic individuals, patient with nutritional deficiencies, poor immunological status. So, as I mentioned, diabetes, nutrition deficiency, also patients who are on steroids, whose immunity is compromised, or immunocompressive or immunomodulatory drugs, such as patients who are on what you call any type of transplant, such as a liver transplant or kidney transplant, who are on immunocompressive drugs such as mycophenolate, mofetil, and corticosteroid for a long time. And also it may be due to local factors, such as directly related to ill-fitting dentures due to xerostomia because of certain drugs that the patient may be taking, and because of the high sugar intake or high carbohydrate diet, and patients who are tobacco users and chronic smokers and tobacco chewers, in them also it is very common. So, management is usually, if it is dentist stomatitis due to candida infection, and antifungal therapy with nystatin and amphotericin will usually take care of the condition. Patient has to be told to avoid wearing the dentures, or if it is very important, just to wear the dentures during mastication, during eating, and to not to wear these dentures. We can correct the ill-fitting dentures by first cleaning them, and then refreshing the tissue surface of the dentures, and then relining them with a tissue conditioning material to act as a bandage and to aid in the healing of the abused mucosal tissues. And as I mentioned, a patient should be advised on effective plaque control measures to maintain the hygiene of the dentures, to use denture cleansing tablets, and which mainly contain sodium perborate. And if there is any like granular type of denture stomatitis like type 3, then it may require surgical excision of this abused mucosa, and new dentures should be fabricated for the patient as soon as possible. And so this is how, using either using electrocautery probe, we can remove the granular tissues from the hard palate, because it may not disappear on its own, and then giving patient with dentures with tissue conditioner, or fabricating new dentures altogether for the patient. The next is the flabby ridges, most mobile ridges, because of the loss of the bone and replacement by the fibrous tissues, is commonly seen in the anterior parts of the maxilla and the mandible, and because of the excessive load from the ill-fitting dentures or unstable dentures. So again, here the flabby tissue needs to be removed surgically, and then after the healing period, a new denture should be fabricated with proper vertical dimension and proper occlusion, specifically balanced occlusion. So these are flabby tissues most commonly seen in the anterior maxilla. Then you have the denture irritational hyperplasia. This is tissue hyperplasia of the mucosa that is in contact with the denture borders. And because of continuous pressure from the denture borders, and overextended denture borders, or due to collapse of the or the settling of the dentures, this may result in irritational hyperplasia in the circular epithelium, and result in excessive tissue growth, which is has a which appears like Epulis fissuratum. So there are folds of tissues with fissures in between them, and as I mentioned, this is due to chronic injury from unstable dentures, due to overextended flanges. And again, these the patient has to discontinue wearing the dentures. They have to be then surgically excised, and then you give new dentures to the patient. Uh, so this is how an Epulis fissuratum is seen due to overextended labial flange of a maxillary denture. So the denture flange needs to be shortened. We can give a tissue conditioner with the denture. Okay, and this is a severe form of Epulis fissuratum, because as you can see here, there is a severe pressure from the extended flange, resulting in the denture rotational hyperplasia. This is most common location of the denture rotational hyperplasia, that is on the labial and buccal vestibule of the dentures. And traumatic ulcers also result from, or sore spots result from the tissue surface of the denture. It may be due to pressure, or maybe due to a sharp edge or the sharp nodule on the tissue surface of the denture. So this need to be corrected. Also, certain predisposing factors, such as, as I mentioned, patients are immunocompromised, taking immunomodulatory drugs, they may develop a traumatic ulcers, and later, if it is not checked, it may develop or exacerbate into denture irritation hyperplasia. So we need to correct the dentures, and give patient lignocaine gel or drops to alleviate the pain, and then ask the patient not to wear the dentures for a few days and till this heals, and gives warm salt saline rinses, which also is helpful in alleviating the pain. And if left untreated, ill-fitting denture flanges may cause first ulcers, and then later they may predispose the patient to precancerous lesions or and ultimately to oral cancer of the denture bearing area or the tongue. So this needs to be this is a very serious concern, and in such cases the biopsy should be performed, and the use of the denture should be discontinued. And later, if the patient has to undergo radiation therapy or chemotherapy or excision, then after that immediate dentures or treatment dentures need to be fabricated with tissue conditioners, and later on, if at all, new complete dentures can be fabricated with soft liners. And another problem associated with dentures is the burning mouth syndrome. It is characterized by the burning sensation of the oral mucosa, and this is it may be due to the burning mouth syndrome, maybe of the denture bearing area, or the patient may have a burning mouth sensation of the tongue. So proper counseling is required. And for the etiology, it may be, as I mentioned, it may be either a local etiology, systemic, or psychogenic. So in local etiology, maybe it may be due to irritation from the denture or allergy to the polymethyl methacrylate acrylic resin or the monomer of the acrylic resin, which may result in burning mouth syndrome. It may also be due to oral habits and parafunctional habits, or it may be as a sequelae of the myofunctional pain. And systemic conditions, we have patient with poor nutrition or nutritional deficiencies, especially older individuals and females. So if there is any vitamin deficiency, iron deficiency, patient needs to take multivitamins, iron supplements, fortified iron supplements. And if it is at all, it is due to systemic conditions that result in xerostomia, and also it is directly related to menopause and diabetes, and patients who are on Parkinson's medication. So these are all the factors that need to be checked and identified. And it may also be due to psychogenic reasons, such as patient who may be depressed, who have issues with anxiety and psychosocial stress. It can also induce burning mouth syndrome. So if it is a local etiology, we can check the dentures and identify them. If it is systemic or psychogenic, then the proper cause needs to be determined and may require counseling or medication or alteration of the life. So next is the gagging. Gagging is most commonly due to the overextended posterior flange of the denture, that is the postdam area. This will result in poor retention. It may create space between the denture palatal vault and the soft palate, and it may result in pooling of the saliva, and the food particles may enter it, and this is usually the cause of the gagging. But also in old denture wearers, this is a symptom of a GIT disorders, as a bulimia, or a patient who is an alcoholic or a severe smoker, and patient with adenoids, that is tonsils. So this may also elicit gagging. So we have to identify whether the cause is due to denture wearing or due to other causes. So next is a residual-rich resorption. Residual-rich resorption is a continuous and ongoing phenomenon, and it cannot be stopped even after the replacement of the missing teeth with complete dentures. So prosthotic factors are, it may be exacerbated due to intense denture wearing, that is patient continuously wearing the dentures 24/7 without any break, without allowing any rest to the tissues. It may be aggravated due to unstable occlusal relationship of the upper and lower dentures, that is problem associated with occlusion. And it may be due to the immediate denture treatment. So in such cases, after immediate denture treatment, after complete healing, new dentures need to be fabricated. So next is the caries and periodontal disease in relation to overdenture abutment teeth. Like we know in teeth supported overdenture, we leave certain teeth, either they are submerged to retain the proprioception and maintain the bone height, or we use the teeth as abutments for the overdentures with maybe with telescopic copings or with bars over these teeth. So what happens usually in old individuals with diabetes and high carbohydrate diet, and due to like denture stomatitis or due to candida infections and many other reasons, poor oral hygiene in with regards to denture, it may result in secondary caries and periodontal disease of the abutment teeth in overdentures. This is very common. So routine appointments, recall appointments are very important in such patients, especially patients who are at a high risk of caries. So in them, the need for maintenance of the denture hygiene, oral hygiene should be stressed out, and fluoride application therapy should be carried out in such patients routinely. And patient should be advised to use denture cleansing tablets on a regular basis, and to brush and clean his dentures regularly. So these are some of the things that can take care of the this problem of wearing a tooth supported overdenture. So other indirect causes of or indirect sequelae of wearing ill-fitting dentures is, one is the atrophy of the masticatory muscles. That is, where due to the reduced bite force and due to poor chewing efficiency from the dentures, this results in poor masticatory efficiency, and also reduced vertical dimension from the dentures results in poor facial support or poor muscular support to the musculature of the lips and cheek and the face, and over time this will result in muscular atrophy and sagging of the face. So in such cases, in order to improve the bite force of the patient, we can give the patient an tooth supported overdenture if he has a few teeth present, or we can give implant supported overdentures or hybrid processes, so that as to maintain his improve the bite force and masticatory efficiency of the patient, and to provide proper facial support, or to improve the tonicity of the musculature. And next is the next indirect sequelae of wearing ill-fitting dentures is the nutritional deficiencies. Due to the decreased masticatory ability, or due to attrition and wear of the denture surfaces, occlusal surface of the dentures, or due to decreased vertical dimension, this may result in poor masticatory efficiency, and as a result, patient has a decreased appetite. He reduces his food consumption. This will result in nutritional deficiencies and weakness, and other conditions such as angulocheilitis and denture stomatitis and denture irritation, hyperplasia, burning mouth syndrome. All these things are the sequelae of nutritional deficiencies. So these things need to be addressed in the patient, especially wearing ill-fitting dentures for a long time. And that brings us to the end of this lecture. Insertion is the overview of all phases of the treatment. It continues through the post-insertion adjustment and recall and review of the patient at regular intervals. However, unnecessary adjustments and mutilation may lead to complete denture failure or failure to comply with the complete denture. The success of the denture depends on the co-responsibility, that a dentist and the patient are partners in the success of the dentures and successful rehabilitation with complete dentures. So this is a very important, and it is a two-way street. So that brings us to the end of